Welcome, everybody. We're going to get started soon. We're going to give it another 2-3 minutes just to let everyone in. But please, if you haven't done so already, drop your location into the chat. And also just notice Mia is in the chat as well, answering questions if anybody has questions throughout. Otherwise, you can just keep asking your questions in the chat and we'll ask Dr. Henne to answer if it's relevant to the slide that she's on. Otherwise, we'll answer at the end. Give people another 2-3 minutes to join before we get started. Thank you everyone for joining us. I'm going to hand it off to Dr. Henne in just a few minutes. Phoenix, welcome. So exciting. Can't wait to get started. Orange County, welcome everybody. All right, we'll give it just one more minute as people are still jumping in. Okay, I think we can start started now. So I want to introduce everybody to Dr. Melinda Henne. She's one of our amazing reproductive endocrinologists at Kindbody, and she is going to be guiding this session. And she is brilliant, and she'll be able to answer all of your questions throughout and at the end. But I'll just hand it over to you, Dr. Henne, to take it away.
Thank you, Sydney. Thanks for the kind introduction. And I just really want to thank everybody who's joining us today. I'm so excited to be here with you, just to talk about the sort of fertility 101 and especially the LGBT experience and how we can help people who are in relationships or that are, I guess, non-traditional in our old-fashioned way of thinking about how they can grow a family and have their own unique family and have their own dreams. So we'll just start with our next slides. So this is some of our Atlanta crew in this picture. And this is just an idea of what you'll see when you come into a Kindbody clinic. We have lots of smiling faces. Everyone's very happy that you'll be joining us. And Kindbody really does want to make sure that everyone feels welcome when they come into our clinics. We are on a mission to make reproductive health and fertility care accessible to everybody, regardless of your skin tone, your eye tone, your hair tone, the partner you have chosen, whether or not you are single or in a relationship. We want fertility and reproductive health care to be available to everyone. We do serve patients directly through employers as a fertility and family building benefit, but we also see patients who might have other forms of insurance or other methods of payment that's independent of their employer. So that's who we are, and then we'll move forward. So this is kind of all of the services that Kindbody does. We do like to consider ourselves a very 360 service. When it comes to fertility, we do everything, fertility assessments, just checking to see what someone's potential fertility status is. We do in-person and virtual consultations. We do egg freezing, embryo freezing, IUI, which is intrauterine or artificial insemination. We do IVF, which is in vitro fertilization. We treat people who need donor eggs, donor sperm, someone who might need a gestational carrier, so a different uterus. We do, there's different kinds of genetic testing that we offer, and we also have some just sort of newly introduced at-home fertility tests that are available to people who may want to do some of their testing in the privacy of their own homes. We also provide gynecology care for people who are born with a uterus. So that includes just basic well-woman checkups, some urgent GYN types of things, but reproductive things related to contraception, pap smears, PCOS, endometriosis, fibroids, as well as some prenatal health. In addition to just those medical services, we also have some full service counseling and other support. We have donor and surrogacy support. We have mental health, wellness, coaching, nutrition support. We even have access for acupuncture and acupressure support that people can do at home. So we try to be 360 and comprehensive for total health care for our patients. And so Move on to our next one, Andrea. So this is kind of just our mission. We at traditionally, fertility services and reproductive health services have kind of been excluded from most employer plans and most traditional like insurance policies because it's been considered sort of optional or elective. And we are on a mission to change that. We feel like fertility and reproductive care for all people is an essential part of being human. It's part of what we are. So we know that because reproductive health and fertility issues, time matters. So we think it's important that we can provide access to reproductive health and fertility care in a welcoming and exclusive experience for everyone as quickly as somebody wants to get in for treatment. Oh, I'm actually seeing a question from Pam about meditation for fertility, vegan options. So that's really interesting because I'm vegan. And so I love to talk about vegan things. We could spend hours talking about it. The challenge for fertility things and vegan options, we can work with a nutritionist, but unfortunately, many of the medications and treatments that we might use for people are not always vegan. Things are developing. But you know, that's near and dear to my heart. And it's one of the things I do talk to the pharmaceutical people about is how can we like change the model of how we get some of these medications. But unfortunately, right now, there's not anything that's like specified as vegan. So, but thanks for that question, because that just got me excited in other ways. So as we talk about our mission, I think it's really important to talk about what we can do to assess people's fertility. So we'll move on. So this is one of my favorite slides because I always feel like the path to parenthood, it is not a straight line for anybody. There's ups and downs, twists and turns. You go upside down. Sometimes you go backwards. Sometimes it goes really, really slow. And then sometimes you're at the top of that precipice and all of a sudden things go really, really fast. The nice thing is you're not alone in this. We are your partners on that path to parenthood. And so we will be hand-holding every step of the way to make it easy as possible for you. So whenever I talk to anybody about what it takes to grow a family, I really say it takes three things. We have to have genetics, DNA, and we get DNA sources from eggs. We get them from sperm. Those two have to combine. And then there has to be a uterus for those combined eggs and sperm, which is an embryo. It has to grow in a uterus. And so then we have to get those pieces of DNA together inside the uterus where they can continue to grow to a child. And so that's where all of our testing will initially come from, is just looking at where we are in that status. And so, so that sort of takes us to where we're looking for testing. So first step.
Inga needs to mute.
So the first step for anyone who is planning a fertility treatment is a consultation. We need to learn a lot about each other. You need to learn about us to make sure that we're your right partner. We need to learn a lot about you and what your desires are and what your path to parenthood is and how we can help you on that path. So if you're born with ovaries, we know that time matters. So women are born with all the eggs they're ever going to have in their lifetime. And over time, there's a continual loss of eggs. And so we may be discussing some ovarian reserve testing, which may be in the form of an ultrasound or blood test. We will offer genetic testing for anyone who's planning to conceive. This initial genetic testing is looking for mutations. It's little pieces of DNA that may confer a risk for offspring to have diseases. These are things that if you carry one gene, you're not affected. But if a person carries two genes, so they get one gene from the egg spore, one gene from the sperm source, then 1 in 4 of those sets of offspring will actually have a medical condition, something like cystic fibrosis, sickle cell anemia, things along those lines. So we do have the ability to test the egg source and the sperm source to see if they carry any of those gene mutations and see if they carry the same gene mutation, which would confer that additional risk. Depending on who is planning on carrying a pregnancy, we may want to check a uterus to make sure the uterus is normal and optimized for carrying a pregnancy. And depending on the route of conception, whether someone wants to do artificial insemination, where we need to have the tubes, the connection that goes from the eggs to the sperm, if that needs to be open, we might want to check that as well. But it all depends on what we find out during our consultation. I do remind people that for women who are in relationships together, they don't really have a diagnosis of infertility, because if they haven't had a source of sperm, they haven't actually failed to conceive. Some people choose to have their tubes checked early on because they're like, if we're gonna go down this route, I want to make sure everything's open. Some people are like, I don't have any really risk factors for having infertility and a tubal blockage, so I might defer doing that testing until later if we're having difficulty. So for when we have eggs and we've checked those, sometimes we need to check sperm if there's sperm available, or we need to figure out where we're getting the sperm if it's for two women who are in a relationship together, or we might be donor sperm, and we'll talk about that a little bit later today. If it is two men in a relationship, or one man who wants to conceive as a single parent, we may want to check sperm to make sure that when we're going through the testing and actually the treatment phases, we don't get any surprises at the last minute where the sperm does not appear as we would expect it to be. And then for people who may not have sperm in the relationship, may not have eggs in the relationship, or may not have a uterus in the relationship, then we have to have the conversation about how we're choosing our donor eggs, our donor sperm, or even our gestational carrier. And so after the evaluation, so we talk about how we're doing our testing. So if we are looking for ovarian reserve, we need to know, like, how many eggs roughly does someone have left, and how quality do we think they are? We know that age is the biggest predictor for fertility problems for people who are born with ovaries, just because there's a continual loss of eggs over time, whether you're ovulating or not. On our webpage, if you sign up for the portal, you'll actually be able to access, you'll see your results, you'll have a definition of what these results mean. And there's even a calculator where you can plug in things like your age, your AMH result, your antral follicle count, and it will give a prediction, like, if we did IVF, how many eggs do we get? If we get this many eggs, what is a chance of a live birth? But in order to test that ovarian reserve and to be able to get those inputs for you, we may want to do an internal ultrasound to look for what we call an antral follicle count. Eggs live in follicles. Antral follicles are tiny little follicles that have been sitting and resting until they kind of get the signal to wake up for that particular month for ovulating. Antral follicles are those little follicles that we can see in the ovary. I always tell people ovaries look like chocolate chip cookies. I love chocolate chip cookies. The chocolate chips are what we see when we're looking at the ovaries on ultrasound. They're little dark spots within a white ovary. We also do a blood test. The hormone we're looking for is called anti-Müllerian hormone. It is actually not dependent on the timing of your cycle like some other hormones may be. It's produced by all the cells that surround all of the tiny little remaining antral follicles in the ovaries. So if I have an AMH level that's above 2, I feel very reassured. I know this is a person who probably has not had a really rapid decline in fertility and would respond adequately or even pretty well to any sort of fertility medications if that's the route we choose. Someone who has an AMH level between 1 and 2, I start talking to people about, we might want to move a little bit more quickly, maybe not like, racing as fast as you can, but we do need to move more quickly because that fertility window in response to stimulation medications may be getting a little bit shorter. For someone who has an AMH less than 1, I really say this is the time when we need to start racing, because we know that the response to stimulation will be lower. Now, just because somebody doesn't respond well to medications and make a dozen eggs doesn't mean they can't get pregnant. So I do remind people that an AMH level predicts the number of eggs we can get when we do stimulation medications, but it doesn't really tell us somebody can or cannot get pregnant. And then, it's also with those results, we have to talk about the rest of the medical history and kind of what your family planning goals are. Somebody who wants 2 or 3 children and has an AMH of 1.5 may want to move more quickly to something like an IVF procedure where maybe we have extra embryos that can be stored and used later on. Somebody who has an AMH of 8 might say, I only want one child, or I want two, and I want them within the next 2 years, and they may not want to be quite as aggressive with treatment. So unfortunately, I don't have a way where I can put a pinpoint on it right now and say, if you have these numbers, this is exactly the path that you go down, because everybody's journey and goals are different. And so we'll move to our next one. So this is kind of, as I talked about a little bit on the last slide when we were talking about AMH, is there's a difference between egg quality and egg quantity. So as women get older, we know that every month one egg is ovulated, but dozens to hundreds more are actually lost as they are providing hormone support for that one that ovulates. And so we're always losing numbers. I think it's kind of an unfair fact of life that we're born with, women with ovaries are born with about 2 million eggs. By the time they hit puberty, they have about 400,000 eggs. So half are lost even before our reproductive years. But there's also a decrease in the quality of eggs over time. It's sort of like the body is saying, when we're ready to ovulate, we're picking our best ones first. And so let's take these best eggs. And so these ones that may be good, but maybe not quite as good, are the ones that are remaining. And then over time, because they've been there, they've been exposed to like all of the things in our environment, whether it's our diet, whether it's, driving down the freeway and getting exposed to fumes, whether it's various things that we're, eating, all of those sorts of things can affect the quality of eggs over time, because those are the same eggs that have always been sitting there. So they've gotten more and more exposures. So we know that quality as well as quantity decreases with age. And we know that quality not only does it make it harder to get pregnant, but it can increase the risk of a miscarriage. And over time, we know that for women who have over age 35, there's an increased risk of having a genetic abnormality because there can be breakages in chromosomes. So for women over 35, unfortunately, we know we do have an increasing risk of conditions such as Down syndrome. And so that's why we want to check those things, but that's why we also talk to people about what their goals and desires are. Because if I get someone's eggs when they're 30, but we don't use them until a person is 40, the risk that they have for a genetic abnormality is really related to the age the eggs were when we actually extracted them from the body. So some people will use fertility preserving things so that they can decrease that genetic risk, but conceive later on. So depending on if there is a person who has testicles and who produces sperm in the relationship, we may conduct a semen analysis. When we're looking at a semen analysis, we're looking at lots of parameters. We're looking at how many sperm are, like the total volume, because that matters, because we're looking at the concentration, how many sperm we have per milliliter produced. A normal value is at least 15 million sperm per milliliter. And then we also look, it's not just how many there are, but how well do they work. So we look at their motility, which is how well sperm move. We want at least 40% moving in a forward direction. Then we look at the shape. People always get confused when we talk about morphology and shape. Shape is really a measure of how well we think the sperm can actually penetrate the shell of the egg to be able to fertilize the egg. People see a number like 4% and go, oh my God, that means 96% of the sperm went crazy. But they don't really. We're not measuring things like, do they have two heads? Do they have two tails? I mean, we are, but that's not what normal forms mean. It's very strict criteria where our embryologists are actually kind of measuring almost with calipers to see how round is the sperm versus how oblong is it. There's a little cap that goes on the top of the sperm where enzymes are. They want to measure that size compared to the rest of the sperm. They measure like the little piece that connects the head and the tail, all of that together. If we have greater than 4% normal forms, we anticipate that these sperm would be able to fertilize eggs adequately. When it's less than 4%, we know that in a laboratory setting, fertilization is not zero, but it is lower. And so for people who have sperm morphology counts less than 4%, often we'll talk about moving towards IVF a little bit more quickly. And so when we are thinking about people who are single or people who are in relationships where they have the same gametes, 2 sets of eggs, 2 sets of sperm, maybe no uterus, we have to talk about what we call third party reproduction. And this is reproduction with someone who's outside of that relationship. So that's really, third party is the term that's often used when we're using any sort of donor gametes. Gametes are eggs and sperm, or whether we're using a gestational carrier, which is a uterus, because sometimes it takes a village to make a family. And so we'll move on to our next one. So I always do tell people when we are talking about selecting a donor, whether it's donor eggs or donor sperm, this is sometimes people go, oh, it's easy, I'll just select someone. But it is not easy because there's choices to be made. When we're looking at egg donors or sperm donors, there's the option of using what's called a known donor, which means you know who the person is. Perhaps it's a friend, perhaps it's a family member, someone else who is graciously volunteered to be donating that sperm or eggs, and they know who you are and you know who they are. Now, for an egg donor, that could be coming from an agency, but it's kind of an open donation. With sperm donors, you can have known, which is someone, and we have to go through that process of making sure they're adequately screened and cleared. Or we can use an agency, which is what we have as what we call anonymous sperm donors. Now, I always tell people there's no such word as completely anonymous in today's day and age, simply because there are all kinds of things out there like 23andMe and Ancestry.com where people can identify genetic relatives just by doing some of their own home testing. And so there are cases where people have identified genetic siblings or genetic relatives of some form just by doing this sort of DNA testing. With egg donors, not only do you have to choose, do you want to go through an agency and do anonymous or maybe an open sort of known adoption? Do you want an egg donation? Do you want to do a known donation with a friend or a family member? But now we also have the decision where we do fresh eggs or frozen eggs. 20 years ago, the only egg donors were all fresh egg donors, and we had to coordinate those donors' cycles with the timing of the recipient cycles. Egg freezing technology in the past 10 years has just gotten so much better that now you don't have to worry about the timing of the donor or finding the right donor and who's the small pool of donors that are available. You actually have the ability to say, these people donated. They had no idea if/when their eggs were ever going to be used, but they donated. They were very generous about it. And those eggs are then divided into various lots, and those lots are then used for donation through egg banks. And I did see someone say, how long is the screening and clearing process for a known donor? And we will talk about that in a little bit. So when we talk about, we have to choose, where's the eggs coming from or where's the sperm coming from, then we also have to think about who is going to carry the pregnancy. If we have someone who's born with a uterus, is that person going to carry the pregnancy? If someone is in a relationship with someone who has a uterus, sometimes there's 2 potential uteruses to consider for carrying a pregnancy. Which person in the relationship wants to carry the pregnancy? If there's no uterus in the relationship, such as in 2 men or 2 people who are born with testes, then we have to talk about a gestational carrier. That can be found as friends, family members, some sort of relationship, or it can also be through agencies to help find those. And so I think we're going to talk about the sperm selection, but I wanted, since I don't see it yet, let's just address it really quick. So the screening process for a known sperm donor, it can be a little time consuming because we do follow ASRM recommended guidelines. So sperm donors, recipients, as well as the group of people, the donor and the recipient together, all have to have a counseling session to make sure everybody understands what it means to donate sperm and what the implications will be. There also is a legal contract that must be in place so that it's very clear from the beginning, before a pregnancy is achieved, what various rights and responsibilities may be for the donor and the recipient, and whether or not they want to have any sort of open relationship, whether or not the donor wants to be involved in raising the child, because sometimes when those issues are, especially when it's families, I think, When those issues aren't addressed early on, like before the conception, it can make things really difficult. Then we have to have medical screening. So sperm donors do have to have screening for certain infectious diseases, things like HIV, hepatitis, and a few others. So we do that blood testing. And then when all of that is done, so the counseling, the legal, the medical clearance for the donor, maybe even genetic clearance to make sure that the donor and the recipient are carriers of the same gene mutations. Then we have to do FDA screening. And the FDA screening is a very specific set of blood tests. And the sperm has to be collected and frozen within 7 days of that screening process being completed. So that's the process. And sometimes it can take a matter of several weeks, but sometimes, usually for a sperm donor, it can take several months just to get all of those things organized and coordinated for people. Sperm also has to be frozen. It cannot be used fresh. And generally the FDA recommends a 6-month quarantine for frozen sperm. Sometimes we can do a little bit shorter than that if we really have a detailed conversation about what it means when we have that shortened quarantine window, and we sign consents for that. So since we talked about donor sperm, so let's talk about what we do with donor sperm. We can do IVF, but sometimes what happens really commonly is people say, I don't really have infertility. My tubes should be open, or we've tested, we know they're open. I want to get pregnant in a quote natural way. They don't want, people may not want to do lots of medications and things that are and procedures that may be involved in IVF. And so we can do what's called an insemination. Insemination really is just a matter of injecting sperm into the uterus. The insemination process, it's a tiny little guide that passes through your cervix. It's about the size of a spaghetti noodle. And the sperm is just slowly injected into the uterus at the right timing in the cycle. Now, how do we know the right timing? We can watch and do some monitoring. Sometimes people want to do things without any medications. We know they're going to ovulate 1 egg that month. And so we watch with ultrasound and blood tests. We may do 1 shot so that we can really time when that ovulation event happens. And that's when we do the insemination. Some people will do what we call ovulation induction with insemination. With the ovulation induction, that means we give you medication to try and get you to ovulate more than 1 egg. And so if you ovulate more than 1 egg, yes, it does increase the chances of conceiving within that month. It also increases the chances that someone might have twins or even triplets or higher. We watch with ultrasound so that we know exactly the right size of the follicle. We know the timing so we can time the insemination appropriately. When people are saying, what should I do? Should I do insemination? Should I do IVF? It depends on a lot of these things we've talked about. What are the goals for family building, and what is a woman's age and ovarian reserve, and are there any other medical reasons that would suggest why she might need ovulation medications? And so all of that has to kind of really be tied together, and that's part of our conversations that we have when we're going through the process. So we'll go to our next one. And so if we don't do IVF, or we don't do IUI, one of the other options we have is IVF. Now, IVF is a much more involved process, and it's really involved, and it's kind of like it's going down that really fast part of the roller coaster for about 2 weeks. Over a 2-week time, we're actually, people are doing injections of medications to try and get a whole group of eggs to grow. Because we're going through all this and spending all of this time, emotions, energy, and unfortunately money, we want to get our best bang for our buck. The hormones that we're injecting are actually the same hormones that your body produces, but we're giving it to people at a much, much higher level to try and kind of those eggs that would be support eggs, we want to get those to be actually ovulated eggs as well. At the end, instead of doing an insemination at the time of ovulation, we actually do the IVF, which is the egg retrieval. Under sedation, there's a needle that's passed through the vagina into the ovaries, and we actually suck out the fluid from all the follicles, give it to our embryologist, and the embryologist then look through all that fluid and they count the eggs. When someone wakes up from their sedation, we know exactly how many eggs they have available. And I did see a question, Leslie said, how many vials of sperm per IUI? I generally tell people per IUI, I recommend ordering 2 vials, but we will thaw 1 if possible, simply because it's really a matter of we need to have a certain amount of moving sperm per IUI, and some labs will sell IUIs at different tier levels. I like to have at least 10 million moving sperm per IUI to give us our best chances for success. And so then the question, and so some people will order multiple vials because if they're not pregnant with their first cycle, then they might have another vial remaining for a second cycle. Some people order multiple because if when we do our first thaw, we don't have enough sperm, sometimes we have to thaw the second vial. And then saving vials for getting pregnant later. It all depends. If we're using a known donor and we have done the freezing of the sperm, that sperm can be stored and there are some fees for that. We may ultimately, if it's long-term storage because we don't know when it's going to be used, may help coordinate to have that sperm sent to a sperm bank for long-term storage. And for people who are buying sperm from a sperm bank, they can actually reserve that particular donor's remaining vials to be held onto for later. It's a little bit of a complicated, more detailed conversation. Short answer is yes, long answer is we would talk about it a little bit more in the consultation. And so we'll go on to our next slide. So this is one of my favorite conversations, and this is the types of IVF that we have when we are in helping people conceive, when there are 2 women or 2 people who have a uterus in the relationship. So autologous IVF means the same person who provided their eggs also carries the pregnancy. Reciprocal IVF is so much fun because one person provides the eggs, but the other person in the relationship. And so it's kind of, so particularly like for 2 women who are in a relationship, this is a really great way for both of them to feel like they are really vital and involved in the pregnancy. Sometimes when we have 2 women in a relationship, when we do IUI and it's one person's egg, she's also carrying the pregnancy, sometimes that other person can feel a little bit left out or a little less involved. When we do reciprocal IVF, both people are involved. And what's even, I've seen this before and it's kind of fun, is where both people will provide eggs at different times and then the other person carries that pregnancy. And so it's the oxygen, the blood flow, that good positive energy going through the uterus is just as important as the DNA, and both people to get to contribute to that for that child that's growing. So we'll go to our next one. So this talks about how we make the embryos. When we are doing IVF, eggs have to be fertilized. So most commonly we fertilize with a procedure called ICSI, which is intracytoplasmic sperm injection, where we actually take a sperm and put it directly into the egg to maximize our fertilization. We start the fertilization on the day of an egg retrieval, and then we grow those embryos and watch as those cells are dividing and starting to differentiate for about 5 days. We can transfer embryos fresh 5 days after the egg retrieval, or sometimes we will freeze them. And they can be frozen and stored for as long as we want. Another one of my favorite stories is the 26-year-old embryo that was transferred into the 24-year-old woman. And so her embryo was actually created before she was born, and she had a healthy baby because of that. Our freezing and thawing technology is a lot better than it was 26 years ago. And so we don't believe that there's a limit for how long eggs and sperm or embryos can be stored. If we want to do genetic testing, so this is a different type of genetic testing, we can actually biopsy and take a few cells from the portion of the embryo that later becomes placenta and check for DNA. So we can check and if we have to, because people have both carry the same gene mutation, we can actually check for those specific genes, but we can't look for all of the genes. So unless we're looking for a particular marker, when we're doing genetic testing of embryos, what we're doing is we're looking at whole chromosomes. So does someone have an extra chromosome 21? Are they missing part of a chromosome 5? Things like that, because we know that when there's an imbalance in the number of chromosomes, likelihood of implantation is low. If implantation occurs, most likely will result in a miscarriage. So if we are doing genetic testing, it does take 10 days to 2 weeks to get the results back. So we have to freeze the embryos because we can't continue to keep them frozen in the lab for that entire time. And so we'll move to our next one. So I do always remind people there's lots of options. An individual woman can choose to be an egg donor herself. She can, because sometimes people will freeze eggs and they might say, you know, I'm not actually going to use them. And if we've done all the right steps in advance, they can be donated. Some people are just really generous and they're like, you know, I want to freeze my eggs for someone else to be able to help grow a family because they know how important that family is. If people have gone through IVF and they have excess embryos, there is the option of saying, you know, I've got these 3 embryos in storage, but I'm kind of done with my family. It's complete. I don't need any more. And so those embryos can be donated for another couple to be able to use, someone else who's struggled. People can do embryo donation to be used with a gestational carrier. And then of course, you know, sort of a last resort for many people is there is the option of just going through a traditional adoption process. Any of those steps along the way, those are things that we can help you with. And we have those services and specialists within Kindbody who can help navigate those journeys. And so we'll move. So next steps. For anyone who's here who's trying to grow their family and thinking about whether they want to do it today, whether they want to do it tomorrow, or maybe someday in the future, sort of the next step is just gathering information. The more you know about yourself, the more you have the information and the power to plan for what you want to do in your future, and learn about those options. So one of those next steps might be scheduling a consultation with a specialist so we can talk about where you are today so that we can plan what you want to do today, tomorrow, or 5-10 years in the future. And so these are where we have Kindbody clinics. So they are scattered across the country. We have them from the East Coast to the West Coast, including in the Midwest. We also do have partner clinics. And so if your employer provides a benefit and you don't happen to be located conveniently to one of our signature clinics, and I can tell you there's a lot more that are opening up this year and next year. But if you're not near one of our clinics, we can help you also. Our patient navigators can help you to find a partner clinic that's near you. And somebody was asking about sperm donor. The age of the sperm donor does matter a little bit, but not until men reach about age 50. About age 50, we start seeing declines in sperm parameters, and there is an increase in certain types of gene mutations that we see in men after 50. So it's kind of unfair that women start having declines in their fertility in their 30s and men not until their 50s. So I do want to tell people that because you came to this tonight, we do have an offer where you can have $100 off your assessment visit. So for someone who wants to use that code, I would recommend, you know, creating your portal. You can actually go online and book your appointment. So I wanted to go through a couple of questions that I see that I didn't answer, and then I'm going to ask the team to help me find others I missed. So one question I see, contraceptives, IUDs, and birth control on the accuracy of hormone and other fertility tests. Great question. There's not an easy answer to this. The short answer is sometimes there can be an effect. We know that for people who are on long-term oral birth control pills, they're not ovulating because of the hormones, but there's still a continued loss of eggs over time. Sometimes we will do the test. So first of all, when we're doing the ultrasound for someone who's on birth control or an IUD, I expect to see a very similar antral follicle count visually, whether or not they've been on IUD, been on a hormone containing IUD, or been on birth control pills. But sometimes the blood testing might look like a little bit less, simply because there's been some chronic kind of suppression of that hormone cyclicity, so the AMH level looks a little bit lower. If someone who is on a long-term hormone-containing IUD, such as a Mirena, a Kyleena, a Skyla, or if they've been on long-term birth control pills, and if I do their blood testing and I do their antral follicle count and everything looks great, I'm like, this is good. But if it looks like it's a little low and I'm concerned and kind of raising an eyebrow, like maybe we need to move a little faster, then I might actually recommend stopping those hormones for 6 to 8 weeks and rechecking. Now, if someone says, I'm going to go through treatment, I don't necessarily recheck. I'm like, I will go based on the numbers that we have. It just might mean I'm a little aggressive to start out with. But if somebody says, I'm not really ready to do any sort of fertility preserving or fertility treatments, then I might say, let's stop those hormones for 6 to 8 weeks and recheck, because then we'll get a much more valid and accurate result. I hope that answered that question. And then tying into that, I saw someone who said, do you need to stop birth control pills before going into the egg freezing process? Great question. Absolutely not. Many times the egg freezing process is actually including a couple of weeks of birth control pills to kind of quiet down and synchronize your ovaries before we start the stimulation medications. So for someone who's already on birth control pills, you stop the pills right as you start the medication. You don't have to stop like 6 weeks or 8 weeks ahead, because you've already done the first couple of weeks of preparation, even though you might have been doing those first couple of weeks for several years. So you don't have to stop more than 4 days before we start your stimulation, unless you wanted to have that validation of what your hormone level is and you've been off a couple of months. But I really think the best predictor of how well someone's going to do, unfortunately, it's not a great predictor. It's actually doing it. Going through the treatment will be our best analysis of how well someone will respond. And someone said fertility and genetic testing now wants to start the process in a couple of years. Would you have to do all the testing again? The good news is your genes are your genes and they're not going to change. And so if you did the genetic screening today, it's done. Now, right now we work with a lab that looks at 502 different genes. I don't know, a couple of years from now, they might be looking at 1,000 genes. And so if you wanted to know all of those extra genes, you might need to repeat that genetic testing to get that additional information. Then the fertility testing really depends. Like ovarian reserve, it can change. And unfortunately, when we do our ovarian reserve testing, it tells us our point in time today. Now, if somebody has kind of a borderline ovarian reserve test result, but they want to wait a couple of years before they do any sort of fertility preserving or fertility treatment options, I would definitely want to repeat it so that we know how aggressive we might need to be. Some of the other testing, there's certain things that would be repeated and other things maybe not. Like if we did your HSG, which is looking at to see if your tubes are open, and you don't have any risk factors for a tubal obstruction in that intervention time, I always say talk to the doctor who's actually taking care of you at the time. But in some cases, that wouldn't be something that we need to repeat. And then long-term birth control, the quality of eggs, great question. And a nice big sigh of relief. You can be on birth control pills from the time you're 15 till the time you're 35. It won't change the quality of your eggs one bit. The only thing that happens is we know there's a continual loss of eggs over time. Sometimes people who are on long-term birth control pills might have something like polycystic ovary syndrome where they don't have regular periods, but you don't know it because the birth control pills kept things really regular for you. Or you're on birth control pills and unfortunately you've got a decline in your ovarian reserve that you didn't know because the pills and the cyclicity of your menstrual cycles is maintained because of the pills. So you might not know those changes have been going on, but the pills themselves will affect it in no way. And we don't see any impact of birth control pills or even a long-term hormone containing IUD on the quality of the eggs, other than just the changes that you see with time. So Katie said, do long-term medications affect the quality of eggs? I think some of it would have to depend on the medications we're talking about. If we're talking about, but in general, we don't think so. Time is the biggest factor.
Thank you,
That's
Dr. We have one more question in the chat here.
I didn't see it. So what's the other question?
Does the age of the sperm donor impact the quality of the sperm, including genetic abnormalities, etc., like with eggs?
Okay, so the only thing for men or sperm donors, age 50. And so most sperm donors are under age 50. We don't see any effects on quality or genetic abnormalities before that time.
Great, thank you, Dr. Henne. Does anyone else have any other questions? All right, it looks like we don't have any other questions, Dr. Henne. Thank you so much for this conversation.
Thank you guys so much for joining me. It's always fun doing these. And I really appreciate the questions that we had today. These were some great questions.
Thank you. And thank you to everyone who joined us. You can visit kindbody.com to schedule a consultation. And we also have that promo code JUN22 running for $100 off. We will share this information with you in an email tomorrow, and we will also share a recording of this webinar to YouTube tomorrow. Thank you, everyone.
Thank you.
Have a great evening, everyone.